all, welcome back to Bemax Academy YouTube live. So it's me Fatima Sia, the MLT trainer from Bemax Kollam. So today we are going to discuss about an important topic from platelet, that is a qualitative platelet disorders. So this topic is very important for the GCC licensing examination. So let's start the topic. So we are discussing about the qualitative problem of platelets. So you all know platelets are the smallest cell in our blood. So platelet having usually the size 2 to 4 micrometer in size, and it having the lifespan of 5 to 10 days. So the platelets are mainly producing from our megakaryocyte. So we can say the precursor of platelet, that is megakaryocyte, that is synthesizing from the bone marrow. So from the bone marrow, the megakaryocyte or the precursor will release platelet into the peripheral blood. So when under the microscopy we can see the platelet having a light blue color granule. So when we are doing the platelet under electron microscopy, we can see inside the platelet the granules are there. Okay, so platelet having mainly two types of problems can occur. It may be a quantity problem or a quality problem. See, you all know about the quantity problem. Actually the quantity problem means it depends on the number of platelet count. If the platelet count is high, that is called a thrombocytosis condition, or if it is low, that is called a thrombocytopenia. So these two are the just a quantity problem of platelet. But you have to know more about the qualitative problem or defect in the platelet structure. So under the electron microscopy, when we are checking the platelet having three layers are there. There is a first layer that is called the peripheral zone, or it is also called the glycocalyx coating. So on the outer surface of the platelet or the peripheral zone, some receptors are there. They are basically called the glycoprotein receptors. See, that receptors are numbering from 1 to 9. So these receptors are very important for the adhesion of platelet to the injured endothelial surface. So let's say that's the condition. So when the platelet having any problem in adhesion, problem in aggregation, or platelet having some abnormalities occurring inside the granule, they all are together called the qualitative problem of platelet. So the first condition I am going to share with you, that is thrombocytopathy related to quality problem of platelet. So simply we know the platelet having the problem, it can be occur either genetically or naturally, that is at the time of birth itself, that is called a congenital problem, or acquired means later in our life a person will be developing some platelet quality problem. It may be due to some viral infections. So basically the platelet having three types of problem are there. That is, the first one is a platelet adhesion defect, second one is a platelet aggregation defect, and the last one platelet release reaction defect. So these three are together called the qualitative problem of platelet. See, the first condition, that is called a platelet adhesion defect. So for adhering the platelet, see, you all know whenever, see, the main function of platelet is coagulation. See, normally our blood will be passing through the endothelial layer without any obstruction. So whenever there is an injury occurring in our blood vessels, the platelet have to come and adhere to the injured area to stop the bleeding. So it having two mechanisms are there. You all know about that, the primary hemostasis mechanism as well as the secondary mechanism. So first starting with the primary mechanism. So when the platelet will start attaching to the surface of the blood vessel, they need some receptors. So that receptors are releasing from the outer coating of the platelet or the glycocalyx membrane. So that receptors are called the glycoprotein receptors. So basically glycoprotein receptor 1B, that is releasing from the first layer of the platelet, that is very important to adhere to the von Willebrand's factor, that is releasing from the injured area. So when there is injury occurring in the blood vessel, the platelet with the glycoprotein 1B receptor come near to that area and they will attach to the von Willebrand's factor to form a clotting. So that will prevent the bleeding temporarily. So this condition having any problem, that may be resulting in a clinical condition called the Bernard-Solier syndrome. So it is very important for our examination. See, the main marker or the hallmark of Bernard-Solier syndrome, that is giant platelet formation. See, normally during this condition, the platelet having a tendency to compare, or they have a tendency to attach together, clump together to form large size. So that is called the giant platelet formation. So let's discuss about the Bernard-Solier syndrome in detail. So it is an inherited autosomal recessive trait. See, autosomal recessive means that is affecting the autochromosome. See, you all know human beings having basically chromosomes are there in 23 pairs or 46 in number. See, the first 22 chromosome, that is called autosomes. So that area having a defect, that is called autosomal recessive. So if both parents having a problem, See, one parent will be giving the defective gene and other parent will be giving the defective gene to the child. Definitely the baby will be developing with these type of genetic disorders. So, Bernard-Solier syndrome is an autosomal recessive trait in which the platelet lack the glycoprotein receptor 1b. So, I told you the first receptor of platelet that helps in attachment, that is the glycoprotein 1b receptor, which acts as a receptor for von Willebrand's factor. So, the glycoprotein 1b receptor from the platelet come and meet the von Willebrand's factor, then only they can combine together to form a temporary clot formation. So, this problem, if that attachment will not be occurring properly, that may be resulting in the clinical condition that is called bruising and moderate to severe bleeding. So, the main complication associated with the Bernard-Solier syndrome, and these two are the conditions, that is qualitative problem in the adhesion as well as aggregation are called the Bernard-Solier syndrome and Glanzmann thrombostomia. So, let us see this image. This is our blood vessel. So, whenever blood vessels having an injury occurring, this glycoprotein 1b receptor that will be come and attach with the injured area with the help of von Willebrand's factor to form a plaque formation. And same like the other condition, other two receptors, that is called the glycoprotein 2b and 3a receptor. These complexes can also attach into the injured area to prevent the bleeding. So, any of these attachment having a problem, that is either deficiency in the Bernard-Solier syndrome, that is due to the deficiency of this particular glycoprotein 1b receptor, or a problem in the 2b or 3a receptor complex, they all will be resulting in prolonged bleeding of the patient. So, these two conditions are called Bernard-Solier syndrome and Glanzmann thrombostomia. So, Bernard-Solier syndrome is a problem related to platelet adhesion. So, this condition are mainly occurring due to the deficiency of the glycoprotein 1b receptor. And the second condition, that is Glanzmann thrombostomia, it is a problem in the aggregation of platelet. So, here the problem is platelet having the 1b receptor is okay, but the receptor 2b and 3a complex, they are deficient, means they cannot attach to the fibrinogen, resulting in bleeding. So, anyway, overall these two conditions are facing in a patient, means definitely they are having a prolonged bleeding. Actually, the bleeding mainly occurring from their nose. So, either in Glanzmann thrombostomia or Bernard-Solier, the symptoms are almost similar. That is epistasis or nasal bleeding. See, that child having severe nose bleeding will be there, then gingival bleeding or gum bleeding will be there, then bruising or ecchymosis we can see in our skin having color changes are there, and petechiae formation, rash formation, prolonged bleeding from minor cuts. If we having a small injury occurring also, the bleeding will not be stopped. Then finally, if a woman having heavy menstrual bleeding or menorrhagia will be occurring, these are the common symptoms associated with the Bernard-Solier as well as Glanzmann thrombostomia. And this condition, Glanzmann thrombostomia, is mainly reporting in female than male. So, the lab diagnosis. So, if a patient having any of this qualitative problem, the mainly when we are checking the peripheral smear, we can see thrombocytopenia. But it depends. Sometimes the platelet may be seen in normal quantity, or the platelet does not have any change in their count, but mainly the problem with the morphology of platelet. So, when the blood film showing the platelet having some morphological changes, in order to identify this condition very clearly, we have to go for a bone marrow examination. See, the bone marrow will be showing abnormal megakaryocytes. See, you all know bone marrow having the largest cell, that is megakaryocyte, they are releasing the platelet into the peripheral blood. So, during this problem, megakaryocyte count will be abnormal or slightly increasing, and the main complication will be our bleeding time is prolonged. So, when we are checking the BT, bleeding time by Ivey's method or Doak's method, it will be prolonged, but the clotting time, normal clot retraction will be occurring. So, these are the main conditions associated with this type of quality problem. Then, platelet aggregation with a normal with ADP, epinephrine, arachidonic acid, but abnormal with collagen and thrombin, and restositin platelet aggregation study was also abnormal. So, for detecting the quality problem, when we are checking the normal platelet count, we cannot get a clear picture about the qualitative problem in the platelet. So, for detecting the qualitative problem, we can use either flow cytometry studies. See, on the surface of platelet receptors, some CD markers are there, especially in the 1B complex, CD42A, 42B markers are there. So, if you are checking the flow cytometric count, we can identify the quality problem, that is Bernard-Solier. Then, in order to detect the quality problem, Glanzmann thrombostomia, the CD41, 61, these type of markers are very useful. Other than the flow cytometric study, we can go for some aggregometry study. So this is type of a spectrophotometrical assay. See, normally inside our blood vessels, the platelet will be attaching properly with the help of some supporting factors, or they are called agonists. They are helping in the aggregation or adhesion of platelets. So they are basically hormone epinephrine or adrenaline, then arachidonic acid, that is a type of lipid, then collagen will be releasing from the injured muscle. They all will be supporting the adhesion, even ADP molecule, they all are supporting. So basically we can say the agonists are ADP, epinephrine, collagen, arachidonic acid, they all will be supporting the platelet adhesion and aggregation. But if you want to check the quality problem of the platelet, these factors we are using for the diagnostic purposes. That means in a different test tube, we have to take the platelet rich plasma of patient suspected of having any of this qualitative problem. Then to each tube we are adding the particular agonist, either first tube having ADP, second tube having collagen, epinephrine, like that we are adding, and the last tube we are adding the restocytin. See, after aggregation occurring or not occurring, we are passing the spectrophotometrical assay. So when the spectrophotometrical light can be passing through means the platelet aggregation will be occurring properly. But if the aggregation is not occurring properly, the light cannot pass because of the turbidity present in the sample. So that turbidity indicating a problem in the quality. Later we are checking the graph, we can see the difference in the quality problem. So these all are the diagnostic purposes we are using for the platelet qualitative problem. See, platelet having aggregation test normal with ADP, epinephrine, arachidonic acid. See, a patient with the Bernard-Solier means with the ADP, epinephrine, arachidonic acid, they does not have any problem. Only problem with the collagen, thrombin and restocytin. So the mainly we are checking the restocytin abnormality in case of Bernard-Solier and von Willebrand's disease condition. So this is the pattern. See, we can use any of the agonists. Basically we are using 3 agonists. So the ADP we are using, epinephrine we are using, and restocytin we are using. So in order to check the Glanzmann thrombocytopenia condition, see, this dotted line represents the normal pattern. When the light is properly passing through, the graph will be coming like this. But if the light is not passing through the sample properly, it is because of the turbidity or it is because of the improper aggregation or adhesion. This graph will be going like this. So here, this is the control they are representing. The dotted line represent the control, and this is the test sample. See, here ADP is not passing properly, then epinephrine also not passing properly, but restocytin is normally going. So that means ADP, epinephrine, arachidonic is not passing properly means the patient having problem, that is Glanzmann thrombocytopenia. But in case of Bernard-Solier syndrome, the condition is just opposite. See, patient suffering from Bernard-Solier means ADP will be normal, epinephrine will be normal, and only the problem with the restocytin. So that is a main point. In Bernard-Solier syndrome, restocytin showing abnormality, and other agonists, ADP, collagen, epinephrine, everything will be fine. Then in Glanzmann thrombocytopenia condition, ADP, epinephrine, collagen, they all are showing abnormal, but the restocytin will be normal. So that is the difference between these two conditions. See, another condition that is called a pseudo von Willebrand's disease. You all know about the von Willebrand's factor. See, von Willebrand's factor will be releasing from the granule of platelet, and it is releasing from the injured area, and it is also a supporting of factor number 8. See, all know factor number 8, anti-hemophilic factor. So the von Willebrand's factor is the main carrier of factor number 8. So von Willebrand's factor having any problem means it can be affecting the primary hemostasis mechanism as well as the secondary mechanism. So this is pseudo von Willebrand's disease. So it is a membrane receptor defect, that is an autosomal dominant. So any of this defect means definitely the patient will be facing, the main problem will be prolonged bleeding. So here, see, normally at the time of injury, the glycoprotein 1b receptor come to the injured area and they have to bind with the von Willebrand's factor. But if the von Willebrand's factor is also not releasing properly from the injured area means definitely that reaction also will become abnormal. So this is an abnormality enhancement binding of von Willebrand factor to platelet glycoprotein 1b, 5 and 9 receptor complexes. So that means von Willebrand's factor cannot be properly bind with the platelet receptor means that will be also resulting in a prolonged bleeding condition. Then see, this is the condition again, the Glanzmann thrombocytopenia. See, Glanzmann thrombocytopenia having ADP, collagen, adrenaline we are checking. they will be genetic defect in the quality of the platelet. See, normally the platelet having the receptor 2B and 3A. They are helping in the proper aggregation. See, you all know in the primary hemostasis mechanism 4 stages are there. At the time of injury, the platelet will come and adhere to the injured area. So, that is the first step, platelet adhesion. After adhesion, platelet will be activating in the area and they are attracting more platelets over there by releasing some factors present in their granules. So, after releasing the factors present in the granules, more platelets are attracting and they will be aggregating one over the another and finally forming a plaque formation or primary hemostasis mechanism. So, any problem will be affecting in a defective aggregation or adhesion problem. So, Glanzmann thrombostenia is a congenital membrane defect. That is also an autosomal recessive trait. That means if both parents having problem, we are facing a severe bleeding condition. Then here there is a defect in type 2 or type 3 complex formation. See, 2B and 3A complex, that is very important for the Glanzmann thrombostenia condition. If a person having 2B, 3A complex are deficient, that will not properly bind with the fibrinogen. So, very important point, 1B is a receptor for von Willebrand's factor, 2B and 3A complex is a receptor for fibrinogen. So, if they are not activating the fibrinogen means clot formation will not occur and that will be resulting in prolonged bleeding. So, these conditions are very common for females when comparing to male. Symptoms are similar like Bernard-Solier, nasal bleeding will be there, heavy menstrual bleeding will be there, epistasis, and the other condition the patient will be facing ecchymosis or purpuric conditions are there. So, this is again Glanzmann thrombostenia, absent platelet aggregation response to ADP, epinephrine, collagen and normal aggregation with the restositin. That is the difference. See, ADP, adrenaline, collagen or adrenaline is also called epinephrine. They are normally with the Bernard-Solier, but a patient suffering from Glanzmann thrombostenia, ADP will not aggregate properly, epinephrine will be affecting, collagen will be affecting, but it will not be affecting the restositin. See, the restositin will be coming to a normal pattern. So, that is a difference. Then the lab diagnosis, when we are checking a patient with a Glanzmann thrombostenia, we can see bruising, easy bruising in the skin, epistasis or nasal bleeding will be there from the mucous membrane, but our platelet size may be normal, sometimes our platelet count may be normal, the lifespan of platelet, that is 5 to 10 or 8 to 12 days, that will be also normal, but here the problem is in the aggregation. If platelet will not aggregate properly, bleeding will be continuing. So, decreasing clot retraction, platelet aggregation test, that is abnormal in primary response to collagen, epinephrine and thrombin, but normal to restositin. That is the condition in case of Glanzmann thrombostenia. So, for detecting these conditions, we can use several methods, that is a platelet retention by using a glass bead method, normal release retraction method and some antibody diagnosis method, flow cytometric method, that is glycoprotein 2B and 3A having some CD markers are there 41 and 61, that can also be using for the diagnosis in flow cytometric condition. See, here you can see ADP is normal, adrenaline is normal, collagen is normal, means this is not a condition of Glanzmann thrombostenia. So, the main difference is in Glanzmann thrombostenia, these three areas having abnormality, restositin will be normal. But here the blue line represent the control and the red line is the test of the patient. So, here ADP is coming normal, adrenaline graph is normal, collagen is normal, but only problem with the restositin means we can conclude this is the condition called the Bernard-Solier. See, that is the main difference. ADP, adrenaline, collagen will be normal and restositin will be abnormal, indicate Bernard-Solier. And if the restositin will be normal and ADP, collagen, arachidonic acid, they all are showing abnormality, that indicating Glanzmann thrombostenia. Then another condition related to platelet quality, that is grey platelet syndrome. So, you all know platelet having 3 layers are there, that is the outer layer that is called the peripheral zone. It consisting of these receptors in the glycocalyx region. And the second zone, that is a structural zone of platelet. So, the structural zone is also called a sol gel zone, it containing the microtubule, actomyosin, skeleton, that are the factors. And the last zone, that is called organelle zone of the platelet, it having different types of granules are there. So, the platelet having alpha granule, dense granule, some lysosomes, peroxisomes, they all are present inside the platelet structure. So, in a normal electron microscopy only we can identify these type of inclusions or these types of granules inside our platelet. See, this is the image of a peripheral platelet count. See, here you can see normally RBCs are there, but in between platelet dots are there, but it is not clearly visible, means see normally when we are doing a right stain or Leishman stain, our platelet having a blue color will be there, but here we cannot see the platelet color properly. So, that is called the gray platelet syndrome. The color of the platelet will be reducing. See, platelets having granules are there. If the granules are abnormally fused, alpha granule or dense granule will not be fused together, means they cannot work normally. So, during this condition, the patient will be facing the problem called the gray platelet syndrome. Then, platelet release having some problem are there. See, first one is the condition, that is these all are congenital, that is genetic problem associated with the patient. So, first one is the storage pool disease. These are a group of hereditary condition which there is defect in release retraction due to the lack of dense granule. See, platelet having granule, alpha granule and dense granule is there. Dense granule is also called the delta granule. It containing some factors, that is serotonin, calcium, ADP. They all are helping in the attraction of platelet to the injured blood vessel to stop the bleeding. But if any of this problem, means definitely prolonged bleeding will be there. So, the dense granule deficiency is called the storage pool disease, or it may be due to alpha granule deficiency. See, two granules are there mainly, alpha and dense granule. Dense granule having problem means the patient will be suffering the condition called the storage pool disease, and if the alpha granule only having problem, means that is a condition called the gray platelet syndrome. So, overall we can say both granule containing ingredients are very important for the proper adhesion of platelet to the injured area in order to prevent the bleeding. Then another condition, that is aspirin like defect. You all know, after surgery, in order to prevent some stroke condition, we are taking the medicine called aspirin. See, if you are taking aspirin, means that will be also resulting in prolonged bleeding. So, here the condition is aspirin like defect, in which the content is normal and defect in congenital deficiency in prostaglandin or cyclooxygenase enzyme. See, when we are taking aspirin, our bleeding will be prolonged. If our platelet will be normal, quality or quantity of the platelet even normal also, the patient have to face a prolonged bleeding during the time of aspirin medication. But another condition, it is not really aspirin problem, this is aspirin like defect. So, like the aspirin medicine, inside our blood vessel we have some enzymes are there, they are called cyclooxygenase enzyme and prostacyclin or prostaglandin. They all will be supporting the adhesion or aggregation of platelet. So, when platelets are properly attaching to the injured area, this enzyme will be releasing cyclooxygenase enzyme. So, if a patient having attachment or aggregation will be occurring properly also due to the deficiency of this particular enzyme. If the patient will be having a proper attachment occur, but due to enzyme deficiency, still the bleeding will be prolonging. That is a condition called aspirin like defect. You all know, after taking the aspirin medicine, bleeding will be, see, when we are doing a blood collection after taking the aspirin, the bleeding will not be stopped immediately. Same like the platelet having quality is fine, quantity is fine, but due to the deficiency of this particular enzyme, cyclooxygenase also, they cannot attach properly. This also will be resulting in bleeding condition. Then the platelet function may be affected by many drugs. See, other than the genetic problem of the patient, we can develop these type of platelet quality problem. It may be due to some medications, it may be due to some food items or some disease condition. Some viral infections, Epstein-Barr viral infection, cytomegaloviral infection, they all can cause a problem in the platelet. They are called the acquired, not hereditary, they are called the acquired thrombocytopathy condition. So, the platelet function may be affected by many drugs, that is drugs, diet and disease. So, mainly the drug like aspirin. See, aspirin medicine having a problem. See, normally in order to avoid any minor clot formation inside the blood vessels, the doctors will be advised to give the aspirin medication. But due to the regular use of aspirin also, the bleeding will be prolonged because of the aspirin medicine, their platelet does not have a tendency to clot. So, definitely they will be resulting in bleeding tendency. Then another condition is called a diet. See, we know our blood vessel having some, they need the support of some vitamins also. See, vitamin B12 or cyanocobalamin, vitamin B9, folic acid, vitamin E or tocopherol, they all will be helping the platelet formation also. But if there is a deficiency of this vitamin, they also will resulting in prolonged bleeding. See, vitamin B12 and vitamin B9 or folic acid, they are very essentially we are getting from non-veg items or fish items. So if our diet containing less amount of this item means definitely the patient will be facing these type of deficiency, and overall these deficiency can be a problem for a platelet low count, that is thrombocytopathy condition can be occurring also due to the deficiency of any of these vitamins. Then another condition is called a myeloproliferative disorder, uremic or DIC, disseminated intravascular coagulation. Inside our blood vessels some unwanted clot formation will be occurring. So during all this condition our platelet will be affecting. So DIC condition, vitamin deficiency or aspirin medication, they all are resulting in acquired problem, not a genetic problem, they are called acquired problem in the bleeding. Then investigation of platelet disorders. See, when we are checking without any diagnosis, the doctors can directly identify the condition if there is bleeding in the mucous membrane. See, nasal bleeding or mucosal membrane bleeding will be very common during platelet problem or a patient with leukemia also. So if a patient will be detecting with any bleeding from the mucus, see, after a minor bleeding from after sneezing also nasal bleeding will be there, or while we are doing brushing also gum bleeding will be there, they all may be an indication of a quality problem in the platelet. Or small skin ecchymosis, after blood collection also some color changes we can observe on our skin, that may also be a problem related to platelet disorders. Then when we are checking the laboratory diagnosis, anyway in order to check the quality problem or primary problem in the platelet, the first step we are doing will be the bleeding time. See, bleeding time, when we are checking the bleeding time will be definitely prolonged, but the clotting time may be normal. So the first line or the simple test for detecting quality problem means patient bleeding time. Then the second line of test, that is for confirmation we are doing the test, that is called the platelet function test. So the platelet function test including platelet adhesion test, platelet adhesiveness in vivo or in vitro. Inside the blood vessel we can do the adhesion, or outside also we are doing with the help of some glass bead column. So they all coming under the diagnosis of platelet related to adhesion. Then for the aggregation defect we are checking the Glanzmann thrombocythemia, Bernard-Solier condition, we are mainly focusing on the platelet aggregation testing. That is the device called aggregometer. It is basically a spectrophotometer. After mixing the agonist externally, we are checking the flow of light. If the light is not properly flowing through the sample means that indicates that sample having turbidity due to improper aggregation, there can be detected. Then finally we are checking the granular problem of the platelet. So these are the basic diagnosis for the qualitative problem associated with the platelet. Now we are going to discuss about the coagulation problem. See, we all know after the primary hemostasis mechanism, see, when an injury will be occurring to the blood vessel, platelets will be attaching properly. So without attachment to the platelet means that is called the quality problem. Then when the platelets are attaching properly to the injured blood vessel, they can stop the bleeding for some time. So they are called the primary hemostasis or temporary mechanism, because they will be again start bleeding if the coagulation factors will not be activating properly. So we all know we have 13 coagulation factors in our blood vessels. They all are always in an inactive form. So they have to activate at the time of any injury occurring in the endothelial surface. So the 13 coagulation factors, you all know very familiar about the 13 coagulation factors are factor number 1, that is fibrinogen, factor number 2 prothrombin, tissue thromboplastin, calcium, then labile factor, that is that factor labile means in heat, in presence of heat they are not active. Then stable factor, they can withstand the heat temperature. And the factor number 8, anti-hemophilic factor. So this is very important. Due to the deficiency of factor 8, the patient will be suffering the problem called hemophilia. Then factor number 9 or Christmas factor will be there. Factor number 10, plasma thromboplastin antecedent. Then factor number 10, that is Stuart power factor. Then 11, plasma thromboplastin antecedent. And factor number 12, Heckman factor, and finally the fibrin stabilizing factor. So you have to study all the 13 coagulation factors in correct order. That is very important for your examination. Okay, so coming on to the coagulation disorders. See, coagulation disorders can be affected in the intrinsic pathway, extrinsic pathway, common pathway. These all conditions are inherited, or later it can be affected acquired also. See, in the intrinsic pathway, see, when studying about the 13 coagulation factors, you have to know very well about the coagulation pathways. So basically the coagulation pathway are divided into 3 parts, that is intrinsic mechanism, extrinsic mechanism and common pathway. So the first mechanism, that is the intrinsic pathway, will be activated by surface contact extrinsic pathway will be activated by tissue contact. So, intrinsic pathway will be occurring inside our blood vessel with the help of collagen, and it have to occur outside means that is with the help of kaolin present in the tube. So, the intrinsic pathway containing factors are factor number 12, that is Heckman factor. So, that is also a question possibly asking for your GCC examination, that is how the intrinsic mechanism will be initiated. So, the intrinsic pathway will be initiated by the surface contact activation, and the factor number 12, Heckman factor, having important role. So, they are called the first member of the intrinsic pathway activation. So, when intrinsic pathway will be activating by the surface contact, factor number 12, Heckman factor, will be activating, and for supporting we need some supporters also. See, other than the 13 coagulation factors, for activating this pathway we need some cofactors or supporters also. So, the high molecular weight kininogen, then pre-kallikrein, kallikrein, they all having role in activating the pathways. So, whenever factor number 12 is activating to 12A, along with that pre-kallikrein will be activating to kallikrein with the help of a cofactor called high molecular weight kininogen. After activating factor 12, factor number 11 will be activating, then factor number 9 will be activating, 8 will be activating. So, they are the members of intrinsic pathway. So, 12, 11, 9 and 8, they all are coming under the intrinsic pathway. So, any of this factor having deficiency, how we can identify? That is when factor number 12 deficiency, 11, 9, 8, any of this deficiency we can detect it by using the test, that is APTT, activated partial thromboplastin time. Then the second pathway, that is the extrinsic pathway. So, the extrinsic pathway will be activated by tissue contact. So, from the injured area tissue will be releasing, the tissue factor will be activating the extrinsic pathway. So, it containing the stable factor, calcium having important role in the overall coagulation system. So, extrinsic pathway having the tissue factor, calcium and stable factor will be there. Intrinsic pathway having the factor Heckman factor number 12, 11, 9, 8 and pre-kallikrein, kallikrein, high molecular weight kininogen, they all are present. Then coming to the common pathway, they both intrinsic and extrinsic pathway after activating, they will activate the members in the common pathway, that is 10 will be activating, 5 will be activating. Then after activating the tissue thromboplastin, they will convert prothrombin to thrombin. You all know factor number 1. Fibrinogen is the factor number 1, prothrombin is the factor number 2. So, first activating factor is prothrombin, that is when prothrombin is converting to active form thrombin, they will support the conversion of fibrinogen to fibrin. Okay. Once the intrinsic and extrinsic pathway will be activated, when the tissue thromboplastin will be forming, they helps in the conversion of prothrombin, that is the inactive form of factor number 2 to the active form thrombin. So, with the help of thrombin only, the inactive factor number 1 fibrinogen will be converting to active form fibrin. So, when fibrinogen will be converting to fibrin, clot formation will be occurring. But the problem is here also the clot will be not a permanent. So, it is a monomeric clot. So, in order to make in a permanent or a stable clot, we need the coagulation factor number 13. So, the name is fibrin stabilizing factor. With the help of coagulation factor number 13, the fibrin monomers are converting to fibrin polymer, and that will be resulting in the permanent stoppage of bleeding. So, this is called the secondary hemostasis mechanism. So, if there is problem in any of this pathway, definitely the patient will be having clot retraction problem. So, the defect we can discuss about the intrinsic pathway, extrinsic pathway and common pathway. So, these three conditions are called inherited or genetic disorder in the coagulation system, and other condition is acquired coagulation disorders. So, let us discuss first about the So, let us discuss first about the intrinsic pathway disorders. So, intrinsic pathway disorders having the main factor, factor number 12 having problem means the patient will be facing. See, when factor number 12 or Heckman factor is very important for the patient. If that Heckman factor or factor number 12 is deficient in a patient, means that will be condition that is clot will be affecting. So, this condition the patient will be facing a problem, that is negative bleeding history. See, normally we know any of the coagulation factors are missing, the patient will be having prolonged bleeding. But if one coagulation factor having a problem, only problem in Heckman factor also, the patient will not be having a proper bleeding, that is called a negative bleeding history. So, that is also a question coming for your examination. കുറച്ചുകൂടെ അല്ല അല്ല കുറച്ചുകൂടെ So let's discuss about the intrinsic. So let's discuss about the intrinsic pathway disorders. So the intrinsic pathway, I already told you that intrinsic pathway containing the Heckman factor, factor number 12, factor number 11, 8, they all are coming under the category of intrinsic mechanism. So here factor number 12 deficiency or that Heckman factor deficiency will be affecting in coagulation problem to the patient. Prekallikrein deficiency. See, prekallikrein and high molecular weight kininogen, they all are supporting the coagulation cascade. So any of this deficiency will be indirectly affecting the clot retraction of patient. Then factor number 9 deficiency, factor number 8 deficiency, factor number 11 deficiency, they all can be affecting. See, factor number 11 deficiency resulting in the condition called the hemophilia C. Factor number 8 deficiency, that is anti-hemophilic factor deficiency, that is leading to the condition called the hemophilia A. And factor number 9, you all know Christmas factor deficiency will be resulting in hemophilia B condition. And finally, von Willebrand's factor. See, why von Willebrand's factor having role in intrinsic pathway means von Willebrand's factor will be act as a carrier molecule of factor number 8. So when factor number 8 have to move properly through the blood vessel means, or they need the support of von Willebrand's factor. So von Willebrand's factor deficiency will also resulting in intrinsic pathway problem. See, any of this problem, definitely a patient will be having the clotting time will be prolonged. So that is the main condition. Then in the intrinsic and common pathway, the patient will be facing the problem, that is in factor number 7 or stable factor having problem, factor number 10 having problem, 5 will be problem. See, factor number 10 and 5, they all are supporting in the common pathway. And factor number 2 deficiency, that is prothrombin deficiency, mean if a patient without prothrombin means they cannot convert fibrinogen to fibrin for the clot formation. Factor number 1 deficiency or fibrinogen deficiency will be affecting, and factor number 13 deficiency. So any of this pathway factor deficiency means in order to treat the patient, we have to provide the patient fresh frozen plasma. That is the blood component of choice for the coagulation factor deficiency. Then especially factor number 2, fibrinogen deficiency, 12 deficiency, 13 deficiency, von Willebrand's factor deficiency, factor 8 deficiency, we are mainly preferring the cryoprecipitate. From the fresh frozen plasma, we are preparing the cryoprecipitate will be very useful for treating the patient with any of this major coagulation disorders. Then acquired coagulation disorders means not by birth or not a hereditary condition. See, acquired means later in the life the patient will be affecting a problem, that is first is the liver disease. If a patient having a problem with the liver, either may be due to some viral infection such as hepatitis B, hepatitis C, or it may be due to liver cirrhosis condition, they all will be resulting in the coagulation disorder. They are called acquired coagulation disorders because liver is the area where the synthesis of coagulation factors are occurring. So if a liver having problem, definitely the coagulation cascade will be affecting. Then the next condition, vitamin K deficiency. You all know vitamin K is also called coagulation vitamin. See the name itself, they are supporting the blood coagulation. During the time of any injury occurring to the blood vessel, our coagulation factors should be activated to stop the bleeding permanently. So vitamin K having important role because vitamin K is also called a coagulation vitamin because some coagulation factors, they are depending vitamin K for their production. So without vitamin K means that coagulation factors will be properly not synthesizing. See, very important point, factor number 2, 7, 9 and 10. Factor 2, 7, 9 and 10, these 4 are called the vitamin K dependent coagulation factors. So the deficiency of these vitamin means definitely these factor production will be affecting and definitely the patient will be having a coagulation problem. Then the next condition is called a DIC, disseminated intravascular coagulation. It may be a problem in the primary and secondary hemostasis area, the fibrinogen will be having problem. So all these conditions are together called acquired coagulation disorders. So if a patient having disseminated intravascular coagulation, our RBC will also undergoing an abnormal shape, that is called schistocyte formation, that is very important related to the condition. So vitamin K deficiency, that is affecting the synthesis of coagulation factors 2, 7, 9 and 10. So basically these 4 coagulation factors are called the vitamin K dependent coagulation factors. So, liver disease, vitamin K and DIC can be coming under the category of acquired coagulation disorders. Then, we have to discuss in detail about hemophilia A or factor VIII deficiency. See, factor VIII is coming under the intrinsic pathway of coagulation cascade. So, hemophilia A is a sex-linked disorder transmitted on an X chromosome by carrier woman to their son and daughter. The defect in low level or absence of plasma factor number 8, which is due to deficient or point mutation. See, factor number 8 deficiency will be resulting in a condition called hemophilia A. It is called a sex-linked disorders. We all know human having 46 chromosomes are there. In that, the last pair, 23rd pair is called a sex chromosome, that is XX in female and XY in male. See, this hemophilia is occurring in the chromosome X, not in the autosomal region. It is a sex chromosomal defect. So, when the X chromosome will be acting as a carrier for this hemophilic gene. So, if there is a change occurring means definitely the mother will be developing the disease condition. So, a female mother with an chromosomal defect or X chromosome problem means if the mother is giving that X chromosome, their children can be affecting, especially the son. See, hemophilic woman will be act as a carrier. See, woman having 2 X chromosome. So, if the mother, a mother can give either a infective X chromosome or a normal X chromosome. For example, if a mother is giving X chromosome to the son, see, in case of male children, father will be definitely giving the Y chromosome. So, the only possibility for getting the X chromosome is from the mother. If the mother is giving a normal chromosome means the baby will be normal, that is XY, normal chromosome will be there. But instead of that, if the mother is giving the affective X chromosome, if the mother having hemophilia affected X chromosome gene will be there. So, instead of the normal X, if the mother is giving the infective X to the son, definitely the son will be having a high hemophilic condition. So, that is also an important question for the examination. Hemophilia will be very commonly affecting or severely affecting males than female, because females are always act as a carrier of hemophilia because they are having one part normal, one part having abnormal. See, if only a single part having problem also, still they are having a healthy X chromosome. So, they can be normally act as a carrier. So, the hemophilia mother can transmit the defective X chromosome to either son or daughter, but if they are giving to the son, they are having more problem. So, that is a point. Hemophilia will be condition will be more affecting males than female. So, this reason is that either the factor number 8 production will be decreased or due to some point mutation, some genetical changes occurring in the production of factor 8 that will be resulting in hemophilia condition. So, according to the clinical condition, the severity can be divided into 3 types, that is silent, moderate or severe. See, mother may be a silent carrier, one part is normal, so she may be a carrier. Then sometimes moderate condition, mildly deficiency will be there or the severe conditions will be there. So, when we are checking the lab diagnosis, the PT, prothrombin time will be normal, APTT will be prolonged, thrombin time will be normal. See, this is very important for the examination. Maybe you are getting case study questions from this area. See, why the prothrombin time is normal? If a patient having factor VIII deficiency also, why the PT is normal means prothrombin time is a test we are checking for defect in extrinsic pathway. See, definitely factor number 8 will be coming in the intrinsic pathway. So, PT will not be affecting. So, prothrombin time will be fine in a patient with factor VIII deficiency, but the APTT, activated partial thromboplastin time will be prolonged because it is a area having the intrinsic problem. So, then the thrombin time. See, thrombin time is a test we are checking for the fibrinogen problem. See, normally prothrombin will be converting to thrombin. With the help of thrombin only, fibrinogen is converting to fibrin. So, if patient will be having a fibrinogen deficiency, that is called a hypofibrinogenemia condition, fibrinogen level will be very low or absent means if we are adding the reagent containing thrombin also. See, for example, if you are collecting a citrated plasma for the diagnosis of thrombin time, we are adding thrombin to the plasma. But if in presence of thrombin, immediately the plasma should form a clot. But if a patient having fibrinogen deficiency means if you are adding thrombin also, it will not be converting, or the prothrombin thrombin time will be prolonging means that indicate the patient having fibrinogen deficiency. So, that is, so it will not be affecting in the factor number 8 deficiency. So, that is why TT is also normal. So, in the coagulation study, the PT, APTT will be only affected in patient with the factor VIII deficiency. Then platelet count may be normal, fibrinogen may be normal, because it is a problem in the coagulation cascade. So, the platelet quantity will not be affecting. It is not a quantity problem. So, patient will be having platelet count in adequate number, but factor number 8 is having deficiency. So, definitely the prolonged time will be showing by the activated partial thromboplastin time. Then for confirming these type of condition, we are doing inhibitor study, that is 50:50 mixture experiment to exclude some inhibitors. That is, we are mixing the patient with a normal plasma. See if the patient normal plasma containing factor 8 will be there. Once we are mixing with the patient sample with a normal plasma, maybe the factor number 8 deficiency is corrected, means that correction we are getting from the normal plasma. But a patient having a problem or due to some inhibitors means that will not be corrected. So, we can discuss, we have to identify the detail of this factor number 8 deficiency by this mixing study also. Then another condition, that is factor 8 assay specific treatment. So, we are checking the specific deficiency of factor number 8 assay also. So, with all of this tests we can confirm the patient will be having a hemophilia condition. Then the treatment of choice. See, the treatment of choice, either we can give the patient cryoprecipitate or we can give the patient FFP, or the best one will be we are replacing the factor 8. If a patient having factor 8 deficiency, we are replacing with a factor 8, means we can resolve the problem. Then the next condition is called Hemophilia B, or it is also called Christmas disease. So, here the problem in the factor number 9, factor number 8 is fine. So, it is a sex linked disorder transmitted on an X chromosome. It is close to factor number 8. The defect is low level or absent of plasma 9. So, factor number 8 will be normal, but factor number 9 having problem. So, either the deficiency, absence, or a point mutation. So, that is called the Christmas disease condition. So, according to the severity, it is also divided into silent, moderate and severe. So, same like factor number 8 deficiency, it is also an X chromosomal defect. So, mother can give this defect to the son, means they are getting more affected. So, bleeding in the soft tissue or joint, very important point, a patient having hemophilia B, from the joints or tissue, bleeding will be there, epistasis or nasal bleeding will be there, hematuria. While passing the urine also we can detect the presence of blood, and post-operative bleeding. See, after doing any surgical procedure or after doing a C-section also, there is prolonged bleeding in a person, means there is a chance of hemophilia B defect also. Diagnosis, prothrombin time is normal, PT is prolonged. So, same like factor 8, factor 9 is also coming under the pathway of intrinsic mechanism. So, here also APTT will be affecting. See, others are normal, PT will be normal, thrombin time will be normal, platelet count will be normal and fibrinogen will be normal. Only problem in the APTT area. Then here also we can do the 50:50 mixture study, but we are not checking the presence of any inhibitors, because inhibitors are more commonly affecting factor number 8 deficiency, and we are going for a specific factor number 9 assay also. So, here also the treatment of choice, maybe we can prefer cryoprecipitate, fresh frozen plasma, or the best one is the factor 9 replacement therapy. Then the last condition, hemophilia C. So, it is an autosomal dominant. See the difference. Previously, we discussed that the sex linked disorder means definitely the sex chromosome are affecting, but here autosomal chromosomes, so that is the first chromosome from 1 to 22. That is called autosomal chromosome. So, it is an autosomal dominant deficiency due to factor number 11. So, it is not a major problem, the patient will be having a mild sign of bleeding only. Here also factor number 11 will be also coming under the pathway of intrinsic. So, APTT will be prolonged, and for confirmation we are going for the factor number 11 assay, and the treatment of choice is fresh frozen plasma. We are not providing factor 11 itself, better we can provide the patient the fresh frozen plasma, that is after centrifuging the plasma from the whole blood, we are keeping the plasma in a refrigerator, freezer at a temperature -18 or below, that is called a fresh frozen plasma. So, we are keeping the fresh frozen plasmas at -18 degree for 1 year, that is a shelf life, and these type of deficiency we are providing the patient fresh frozen plasma. So, these three are the factor number 8 deficiency, factor number 9 deficiency, and the factor number 11 deficiency or hemophilia disease. They all are coming under the coagulation disorders. So now we can discuss some questions related to the topic I discussed today. So the question, a 3-year-old boy present with frequent epistasis, gingival bleedings in infancy, his platelet count is normal but the platelet aggregation study shows absent aggregation with ADP, collagen, epinephrine and normal with the aggregation with the rustocitin. See the condition, a 3-year-old baby boy with the epistasis, that is nasal bleeding will be there, gum bleeding or gingival bleeding will be there from the very early infancy. Now the baby having 3-year-old. So his platelet count is fine but the aggregation study shows ADP, collagen and epinephrine absence aggregation but the aggregation with the rustocitin will be normal. So already we discussed in the aggregation study, ADP, collagen and epinephrine are agonists supporting the platelet aggregation. So if these aggregation factors having problem and rustocitin is fine, means the baby will be suffering from the condition called the Glanzmann thrombostomia. See, Glanzmann thrombostomia is a clinical condition developing in children, that is due to defect in the glycoprotein 2B or 9 complex. So these complex deficiency will be suffering with the bleeding. So the baby will be developing prolonged nasal bleeding, gingival bleeding from the infancy. So when we are checking the platelet count, the count may be normal. So only the first step we can identify with the help of bleeding time. So maybe the baby having the bleeding time prolonged. So in order to identify these type of qualitative problem, we have to go for the detailed platelet aggregometry study. So on the aggregometric report if showing the agonists like ADP, epinephrine, arachidonic acid having a abnormal aggregation and the aggregation with the rustocitin will be fine, means we can conclude the baby having Glanzmann thrombostomia. But we can discuss the other option also. In case of Bernard-Solier syndrome, only the rustocitin aggregation will be abnormal, others will be fine. See, instead of here, ADP, collagen and epinephrine will be showing a normal pattern and the aggregation with the rustocitin showing an abnormal pattern, means that indicates Bernard-Solier syndrome. So these two conditions are very important. You have to study in detail about these topics. So thank you all.